Great to see so many new and returning friends on the Echo today. It's a good crisp morning here, which means I had to turn the thermostat up. It seems like fall has finally arrived. So I just want to start off by reminding you this Echo is a collaboration with our Heartland Telehealth Resource Center, and then our Missouri Telehealth Network. And then some folks I know are coming with the Echo, and some folks are with the Echo plus our telehealth collaborative. So just welcome everyone. And if you're interested, we can also share at the end some information about the broader collaborative. With this Echo, it's really the idea of, we ran with telehealth during the pandemic, and now as we're looking at sustaining and expanding, what's some of the operational, clinical, legal, regulatory, and evaluation elements that can help continue to grow telehealth. So I'm Eve-Lynn Nelson, and I have the privilege to moderate these sessions. Everyone, I think, is one step ahead of me today. Great job. It looks like most folks have already typed in their name on the Echo screen. I want to start off by just introducing our Hub team members. So I'll start off with Tim. Would you mind introducing yourself?
Absolutely. First thing, all right. Tim Davis, telehealth manager here at Oklahoma State University Center for Health Sciences in Tulsa, and the Oklahoma representative for the HTRC.
Super. Good morning. Karen?
Hi, everybody. I'm Karen Edison. I'm the Senior Medical Director of the Missouri Telehealth Network and our Show Me Echo program.
Super. Good morning. And Robert?
Hi, I'm Robert Stiles with University of Kansas School of Medicine. I work with HRC, especially in areas of policy.
And Christy?
Hi, I'm Christy Gagne. I'm from the University of Kansas Medical Center, and also work with the HTRC doing communications.
You know, I'm scrolling real quick. I don't believe there's anyone else on the Hub team, but please do chime in if I've overlooked somebody. Great. Go ahead, Beth.
No, I said you said everyone.
Okay, super. Thank you. It looks like we have over 30 on the line today, and I know we have quite a bit of material to cover. So we really would appreciate if you participants, if you introduce yourself in the chat, and then we'd love to hear you in the presentation. So please do feel free to type questions in the chat. Also feel free to unmute yourself and share your question. And I know that Beth will be helping us keep track of, if you raise your hand in the chat, we'll keep a track of that too. Finally, just a few announcements. You may recall for our environment, we're really aiming for our first names only. Just be conscious about any kind of protected health information. I don't think that'll be coming up today. And then please do keep your microphone on mute until ready to speak. And then just to plug, we'd love to hear some of your cases as we progress through this 10-month Echo. So please keep in touch as you have cases to share with us. So with no further ado, I'm going to share screen. And so today our topic's needs assessment. I know that we have many experts on the screen across our participants and our sites. you've seen one needs assessment, you've seen one needs assessment. So we're really looking toward some general information with the slides, but really want to hear from you. You may have done things in needs assessments that really helped, so you'll have tips for us and to share across the group, or you may have tried something that, boy, that just wasn't a fit, and that's equally useful because I know we're all trying not to reinvent the wheel. So today's goals are to go through the eStart, which is our readiness assessment tool with the Heartland Telehealth Resource Center, and focus on the needs assessment. And you may recall that these questions will be sent via RedCap right after our meeting today. And we ask that the participants complete that by our next December telemedicine echo. And then the second part will provide some tri-state examples of needs assessment following this template. So, I know this is a bit singing to the choir. It's what happens when you put the psychologist on the team in charge of the slides. So, I know we all know this. It's really more the journey with needs assessment that really has the most power. We do want to get to a destination where we're taking all the needs assessment information and letting that inform our journey. But it's really the process of, getting folks around the table and continuously seeking input that the needs assessment helps. So I think with the journey, again, we came to the journey with many COVID impacts where existing telehealth programs have just, grown super fast and providing a lot of needed services. And now we're looking at, which pieces are we looking and are a fit for our current needs, and how to prioritize resources to look at meeting those needs. I think all of us, when we start needs assessment, we're thinking about who needs to be on the road trip. So who on our internal team needs to be part of the discussions, and then who on our partner team and other community team needs to be part of informing what the needs are. I think much of what we talk about, it parallels the start to any new or expanded clinical service, or for that matter, I know a lot of us are looking towards more teleprevention and using the technology broadly. So it also can help across those services, but just kind of informed by if we were starting a new on-site service, we need to think about these same kinds of needs assessment questions. And then finally, thinking about the needs assessment as a key component of our ongoing continuous improvement processes. So, there's needs assessment, and then there's a continual, what's our next needs assessment, and building that into our processes where it's an ongoing discussion across our internal and external partners. So I just want to walk through some of the eStart telehealth readiness assessment general questions. And I'd like to give you a minute just to read through them. And then I'll just add in, I think when I read through this and think about our own telehealth services, it just prompts me that, gosh, I know someone on my team knows this piece of information, and so I can reach out to them. I think that with the needs assessment, it's a chance to reach out to each of the folks who has that piece of information, and then pulling it all together. So across the team, kind of it's that broader picture where everyone more has an idea about these critical components. This also reminded me that a lot comes from our mission and vision with the particular telehealth service. So I think as we look at these general questions, it kind of points me toward thinking about, are there other questions I need to think about, or how do these questions, how does it all fit together with our overall mission and goals? I'm curious with the audience, are there any of these questions that really resonate? And, there are ones that you would for sure put on your needs assessment. And then I'm also equally interested, any surprises on this list or anything that you all would add. Is there any one of the pieces of information that folks think would be particularly hard to get? It looks like we have a comment in the chat. Thank you. So the comment says, I think what my providers and team struggle with is what are appropriate things to see for telehealth and what are not. So really looking at patient appropriateness, that's an awesome point. And then another a person, Alex, comments that we are in a holding pattern for telehealth because our billing department does not know about reimbursement, which is a great point. And so much is in flux right now. Just to put a plug in for our telehealth resource centers, we do have a billing and coding lead to kind of help answer some of those questions, but some of it is a bit unknown for all of us as we see how the policy lands. And then Heidi shares that my organization is not comfortable because they constantly share that there's concerns about what's covered in rural health. So again, looking toward policy needs. And then sharing that some PCPs are afraid this will redirect their patients to other providers. So those are all great questions. And I think all those could be framed in some of these general questions that we're looking at with the readiness assessment. I'm going to go down to the needs assessment specific questions. And again, I think the questions, I think, as you read through them, they're not hard questions, but they are ones that just, it takes some time to gather each piece of information and then to think through how do we share it across our internal and external teams to really help prioritize the resources that we have to meet the highest needs. Again, with this one, I'd love to hear in the chat, or please do unmute yourself about anything that's a surprise, anything also that you would add. The policy questions that were just mentioned are really important points. Beth, do we have any comments in the chat or anything before we move from the needs assessment list to the next slide?
You have covered everything in the chat that I have.
Okay.
That I see as well.
I might, before we jump to the chat, I might ask our cross-state partners, Tim and Karen, are there any things on this list that really stand out that you would prioritize and make sure every needs assessment addresses?
I guess even right now, my brain is doing is I'm wanting to respond to some of the people in the chat and answer some of these questions. Like what the providers are like, what is appropriate, what's not appropriate for telehealth? Really, you guys, you should leave that up to the people, the actual professionals using the technology, because they're the ones who are going to say, I can do this safely, I can't do this safely. That's not a decision for the administration or for policy. It's really up to the professional, the healthcare professional, to know what they can and cannot do and what's appropriate. And then the two comments that it's not covered for rural health. I mean, you know, back in BIPA 2000, I mean, rural health was prioritized. Telehealth's been paid for through Medicare in rural health since 2001, the same as in-person care. So I'm not really sure where that comes from. And most states, including our states, have paid for rural telehealth for a very long time through the Medicaid programs and our insurers. So I don't know where that thing about not being covered in rural health comes from. I'd be interested.
Can I speak up?
Oh yeah.
Because that was my statement. I didn't say it isn't covered. The question was, are there issues with organizations? And what I said is, the organizations have this belief that it isn't covered, and that is very real. And several people did kind of agree with me on that.
Well, that's wrong.
It may be wrong, but that is still a very held belief amongst billers in the organizations, and I fight that.
Yeah, this is Robert. My question is, what type of entity are you? Are you a rural health clinic or?
I'm a rural health clinic, yeah.
So that gets into the distance issue, which during COVID, it does not matter, but serving rural health clinics cannot serve as a distance site. So after COVID, unless the law or the rules are changed. And most of the bills that are in Congress related to telehealth right now across the board want to change that. And I think that's one of the things we're going to see changed as soon as kind of Congress actually acts on any of these bills that have telehealth in them. But I can understand that concern because it is true that you can't serve as a distance site outside of the COVID emergency.
But since COVID, everybody has been saying that we should hang on to that. So I think that we'll hang on to it.
Right, but the problem is when you're I'm in a really tiny area in Oklahoma. And so when you get into some of these small areas, they're a little sometimes behind in knowing what is and isn't going on. And so, you know, they may not necessarily know what is and isn't allowed. So what was allowed for the last 20 years, maybe what they still think is okay. And they may not be aware of the COVID changes. And that's what I'm facing. And that's the problem.
Yeah, I think what you're saying is the perception has as much impact on the behavior as the, reality. And so, how can a needs assessment, how can it potentially inform with what's the landscape now?
Exactly.
I think it's a great point. And I think it's one that, how do you have the right the people at the table who can help share some of that latest the latest policy and what it looks like now, but that's a tough one.
So this is Derek Landis, and I'm working in rural Missouri with quite a few hospitals. And just to back up what you're saying there, what I see a lot is even the hospitals or systems that are aware of the COVID policies, there's a hesitation to do anything until everything is solidified. And we know what it's going to look like post-COVID, because nobody wants to put in the work and the resources if we don't know what's actually going to be approved by Congress at the end of this.
Yeah, excellent point. I think some of the needs assessment piece can go forward to kind of gather information about what the needs are, even as we're waiting on some of the policy part. But I totally agree with what you're saying, that there's a hesitance and it's hard. I mean, how do you business plan before some of the details of the reimbursement? So that's a really that's a tough one.
Eve-Lynn, I think that kind of leads into what I like about this needs assessment is it just, before you kind of read through it, you don't really understand every piece of the organization that needs to be brought to the table, from finance to marketing to providers to administration to nursing to IT. You pretty much name it, and everyone needs to be there to see does it fit and how they fit into this plan, and how they can benefit on their side and then provide a benefit.
Yeah, great point, Tim. I was thinking some of that when you were sharing, Karen, just how important for patient appropriateness, how important, and vital the clinician's input is, making sure there's clinicians at the needs assessment table with the services that you're looking at providing, and having that voice around patient appropriateness, safety considerations, all those important concerns.
And just to kind of follow up on that a little bit, I know when we open up maybe a new clinic or a new telehealth site, that's one of the things I never kind of assume what the provider will need technology-wise. So we always, again, make sure they're there, what kind of patient we're going to see, and then what does the provider need and want in the way of technology, and then, go from there, instead of just assuming here's a basic kit, everyone gets the same thing. Maybe they don't use the technology piece, and so we're wasting money, or maybe they need something else that we don't have, and we're not, benefiting the patient. So that's a great point.
Yeah, that's a great point. I know, of course, my team is in the same boat where sometimes we get really excited about the technology, but then, really looking to the clinicians, is this going to do something above and beyond? Is it, really going to match up to the need that the patients you see have? So thank you for that point. I am curious, folks in the participants, if you have guidance about in needs assessment, how have you got that clinician voice, or are there some strategies you've used in needs assessment, or people you've had at the table that have helped with both of these things we're talking about, with the patient appropriateness and making sure there's a clinical voice, and then also just with the policy component, and how to move beyond perception to kind of the accurate landscape of the policy today, and not thinking about 10 years ago, but really trying to look at what's accurate for today. I'm not seeing any questions. Please, Beth, if there's any comments that are new, keep me posted. I think with that, we'll move to Missouri's example with the needs assessment, and some of the key considerations they found with the wealth of many needs assessments.
I put this slide in. This is sort of like needs assessment for the non-process people on the call. It's a little more direct. And I think the most important question is, what kind of telehealth do you want to do? When people say telemedicine or telehealth, it's always instructive to say, what are you thinking of? Because it's such a broad field, right? So are you talking about using the technologies to do follow-up care for your existing patients? Are you talking about doing follow-up care for your partner's patients, and where you have access to the electronic health record? Are you talking about reaching out to new patients? Are you trying to build a patient base, for example? Are you really just wanting to access specialty care for your patients? That's a totally different kind of consideration. Or do you want to do monitoring for your patients who have chronic diseases and are on multiple medications and maybe have frequent hospitalizations and things like that? So there's so much in here that is a consideration, or maybe you want to do several of these things. And so I think it's important to answer those questions first. Healthcare is best if it's regional, if not local. Healthcare providers in local and regional areas know more about the culture and the resources and the infrastructure surrounding the patients. And so we like to keep care local if we can. I always say it needs to be integrated and coordinated where there's ample communication between the care teams, not disconnected and anonymous. And so that's something to keep in mind as well. So follow-up care for existing patients, video, if you're going to access specialty care for your patients, sometimes you can do that in certain diseases with store and forward, like dermatology. And then the home monitoring kinds of situations are really for the chronic diseases and care into the homes. And that's one of the, I think, most useful changes in the public health emergency is letting telehealth be delivered in patients' homes. And I see that it has really been beneficial for 3 groups in particular: frail, elderly, and or disabled. I put in one group, parents of small children, both for the parents and the small children. And then thirdly, mental and behavioral health patients. Turns out patients really like to be able to access their mental health provider, from their car, from their bathroom, from their phone, wherever they are. And so I really hope that the home stays in. And I'll just remind you guys that the public health emergency is scheduled to end in January of 2022, but somebody, there's rumors that it might get pushed back, right? Where's Robert? Yeah, I don't see him, but anyway, there's rumors that it might get pushed back till next summer. So we'll see about that. But like we've said, I really think that a lot of these telehealth things that we've seen that are very, very useful, I hopefully will stay in place. And then lastly, do you have the organizational commitment and resources that you need? Is your leadership on board? That's huge. That is huge. Is your leadership on board? Are they supportive of what you're trying to do via telehealth? Do they understand that everybody else is doing telehealth, including your competitors, and that they need to be committed to this as well? And I'll give you a little example. Well, it's a big example, but it's instructive, I think. I'm a dermatologist and I practiced teledermatology for 26 years before I retired in May of 2019 from my clinical practice. And I practiced all that time. I'm in Columbia, Missouri, and the university is right across the street from our VA. So I always practiced part-time at the VA. All of our faculty did. And it was interesting because we did teledermatology at the VA starting in 1995, I think, and had done that all along. But the VA in general really wanted telederm to get started more widely because half of our veterans have multiple skin cancers. And so they were frustrated because they just couldn't get it going. So you'd have mission-based people here and there, but VA couldn't get telehealth started in earnest, telederm. So in 2012, they said, we're going to do this. And what they did is they put a clinical coordinator in every medical center. They put a technical coordinator in every medical center. They incentivized the care. I was chair of the department. They would give me 30 minutes faculty salary time for every store and forward teledermatology visit my faculty did. And it doesn't take 30 minutes, and they knew it. So they incentivized it. And then they wrapped quality assurance and quality improvement programs around that service. And they did all that in 2012. And by 2014, the VA was doing like 150,000 telederm consults a year, right? So that's a big example. But what the instructiveness of that, I believe, is you really need organizational commitment because there are resources that are needed. Now, they don't have to be that robust, but you do have to be willing to carve out part of somebody's FTE to make this their job in your organization. And so, I know in a big organization like the University of Missouri, Carrie Jones is on the call and that's her job. But in a very small organization, you're not going to have a whole person who's going to be your telehealth person, right? You're going to have a part of someone, and a part of someone who can be the technical resource. And then maybe a part of someone, those are the most important things. And then it's got to be incentivized in some way. It's got to be valued. And those are the pieces that are, I think, the hardest. And so we are here, the Heartland Telehealth Resource Center in this Telehealth Echo, and we really, really want to help each and every one of you with this journey. So I think I'll stop there. And if you're the telehealth person in your organization, you're going to get asked a lot of questions by people who don't know anything about it. And I'll just remind you that the answer almost always is just the same as in person, right? So it's not different care. We're just using technology to bridge distance and sometimes time and distance. And so, how do you schedule the patient just like in person? How do you do that just like in person? How do you document just like in person? So that's almost always your answer, just like in person. It's not something sort of special and crazy and different. It's just using technology to extend your care. And by the way, people will also ask you about the technology. And, the technology has been excellent for a very long time. I started doing teledermatology in 1995. And in the right around 2000, the high def revolution happened and everybody thought dermatology needed that. And I was like, well, no, we really don't. I mean, the cameras have been excellent for a very long time. And so the technology has been excellent for a very long time. So anything you can do with a scope, anything you can do with a camera. So I think I'll stop there. And I'd be happy to take questions.
Thanks. It looks like we might have a question in the chat. Beth, if there's a question for Karen, please chime in.
Alex wrote, these are all good questions. What about policy creation? And then Robert said, Alex, you're right. As you guys are an FQHC, it's RHCs and FQHCs that outside the current emergency may not serve as distance sites, at least through their cost-based PPS payment vehicle. We will have Rochelle Martin, who leads our billing webinars and is an attorney and a certified biller, lead our discussion on policies in the session on billing.
Thank you.
And that's just that HTRC's billing person. This is a great partnership between multiple entities. So I accidentally used R there. We're really excited to have Rochelle join us. And she will definitely go into how to create policies, but especially if you're an FQHC and RHC. Not to get too complicated, and we'll get there, but it is possible to bill. You just have to do it outside your payment structure, right? You can get a billing number that's not the RHC or the FQHC, but I don't think we're going to need to get there, because what I really think is going to happen is these rules are going to change. Everybody agrees they need to change. It's just a matter of when.
Great point. I will make sure that with the resources sent out, some of Rochelle's presentations are archived around policy. And then, as Robert said, with the changing landscape, Rochelle will have some upcoming presentations that we can share with this group. I had one question, Karen. I think one thing our team sometimes has struggled with is we think we have organizational commitment, and it's, yeah, that sounds great. And then it doesn't sometimes, it wasn't as strong a commitment as we were thinking in terms of resources. Is there anything you look at that's kind of a sign of that commitment? It kind of guides you?
Mm-hmm. So I always say, it's a leadership issue, right? So if the leadership says, this is a value and this is one of our priorities moving forward, then how does a leader demonstrate that? Well, they put resources behind it. and support behind it. And if there are no resources dedicated to supporting that activity, it's not a priority. So that's sort of stating the obvious, but that's how you see if it's a priority for the organization. If they put, doesn't have to be huge resources, but it has to be some resources to help support that activity.
Well, I think it's really good as we're trying to look at this list of needs assessment questions. I think you're suggesting make sure you're direct and ask both sides of the coin. It's great to have the yes, but the other side is asking about, well, what's that look like in terms of resources? So we're going to just share one of our examples that's hot off the presses from our Kansas Telehealth Rocks team. And this is real processy. So it's kind of, we're addressing both types of learning styles. So I wanted to share a recent needs assessment. We went down and met with our partners on a expanding project. It's a partnership between our university and our researchers and evaluators, our community health center. That's the 18th largest community health center in the country, and then a diverse rural school system. And so we've been working together in a partnership across the last 5 years. And then we're fortunate to have on our team kind of borrowed equity and folks who've worked with those partners over many, many years. And so with this new iteration of our school-based telebehavioral health, we're fortunate to add more resources around social determinants of health with the addition of community health workers. And then the teleclinical services we're able to provide to the home, the school, or the clinic, really more driven by the patient and family and their choice for their child. So it's exciting to have those new funded projects, but it's also a bit going again and really hearing what's the needs today, and trying to understand, that's going to inform who we hire. It's going to inform how we revise and fine tune the approach. So last week it was awesome. We had such a warm welcome from our sites. Most of the team was able to go in person, and then some were able also to join via video. So I just thought that was a good point that, you can do good needs assessment with video and phone and gathering all that information. It's always great to meet in person and valuable when we can, but both were really useful, so we could cast a wide net and have a broader group at the table. So just with us and looking at needs assessment last week, it was a really big table. So really, I think your leadership point really resonates, Karen, where we had the superintendent and the CEO and CFO and all those, and also clinical leaders, but then just also the teachers from every grade level, the school-based behavioral health teams. We didn't have parents at this first meeting, but that's certainly our next focus, is having more parent and community, broader community input. Also bringing on our communication folks, our education folks, our trainees who are involved with the project, and also our app developers. I'd really ask Robert, I know you're the project director, so I appreciate if you could add in any needs assessment parts that I'm forgetting. looks like Robert may have needed to step away for a minute, so I'll just continue on and he can sure chime in here in a minute. So what we really heard, it was similar to what we anticipated with child telebehavioral in the school and clinic, but the real focus that was newer was just how the teachers were just so much struggling with some of the classroom strategies, just supporting children who'd been traumatized through the pandemic, and then across many other traumatic things with new immigrants, and also with just an overall series of longstanding traumas, and also some from natural disasters that had occurred in the area. And then really listening about how could we help address some of those needs, as well as the teleclinical. And then there was a strong interest in just, there's so much need with the students. How can we look towards some short modular therapies, and also so kind of real solution focused brief interventions, as well as access to longer term therapies and psychiatric care. And then also what came out was a lot of interest in, what kind of trainings can we do over the telehealth system as well. CARES is a specific type of fun training around child-adult relationship enhancement, and really, with teachers, paras, and others, really reinforcing some of that child engagement skills that also help with telebehavioral health. We were really fortunate. Our partners brought great data really to also inform the need, with the community health center sharing data around, what patient presentations folks are seeing, and what their clinical providers are hearing in terms of needs. And then the school district brought their I think it's panorama information about, what are they seeing with students, and the self-efficacy of students, and the engagement, and the worries and concerns of students as well. So just, again, I kind of leaned into the process part, where getting all those folks around the table, around the the telehealth services, has really helped us more fine tune the approach on the current needs. We do still have quite a bit on our plate, with needing to look toward next steps with technology resources scan, both our connectivity, and then also our technologies, and then looking at our communications planning to continue to get the same kind of feedback across the course of the project. And then it really has informed some of our hiring needs, with our community health workers, but also with hiring other positions. So again, I'm not sure if Robert's been able to join us, and he can sure share additional information. And then Christy, I know you were on the needs assessment trip as well. So please do chime in if things come to mind about that, how that helped, how it really helped inform our next steps.
Sure. Well, I can chime in on the training part. It really helped to hear what they needed and what they didn't need. A lot of teachers already had some of the training, but wanted refreshers. And so, not counting it as once they've been trained, they're good to go, mentioning that they needed some refresher training. And then some very specific needs that they were having in their schools. They need some kind of keeping kids safe, suicide focused echoes. And then parent training was mentioned both when we talked to the clinic and the school. And so we're looking at, what needs we can fill there. And just kind of, we also looked at some repeated themes that came up in both conversations. So it was nice to see like some of the needs do match. So both of them talked about mentorship. Both of them talked about community trauma awareness and parent training. So that way we can kind of look at what trainings will go across the board for both of those locations, and really make sure that we can meet everyone's needs that way.
Wonderful. I guess I'm curious, I don't know if others kind of, if this sparks some ideas about, you know, who all would you think about adding to your needs assessment team? Again, this is just our journey, but it was really, really helpful to have such a breadth and depth of knowledge in informing our next steps. And I have to chuckle a little. Robert has just texted that his electricity's going on and off, so he got kicked off. But it also speaks to our needs assessment and planning. What do you do with the telehealth technology when you have a situation where, you know, your electricity's going off, or, you know, your connectivity goes down, and some of those things you have to think ahead of time about. It looks like we may not have any new comments. Is that right, Beth?
That is correct.
Please do unmute yourself if you have any comments. With that, I'm going to go to our Oklahoma partner. I know we put you in a tough spot, Tim, because I know we've talked an awful lot about some of the high points, but we'd love to hear from your examples in Oklahoma. I've been so impressed with your work, and Dina and Heather, with some of the health equity that I know you kind of bring into some of your needs assessments with diverse partners.
Oh, thank you. Yeah, not to echo, no pun intended, what Dr. Edison and Nelson has said, but yeah, I probably will be echoing. Pretty much, we kind of started a little pilot project with a very underserved community, about 45 minutes away, and has a high elderly population. So a lot of them don't drive, etc. So we looked at putting a telehealth cart and provider out there, or nurse out there as well. And some of the things we looked at again was what did the community need? What did they want? What type of patient? Was it a specialty? Was it a primary care? Even from a reimbursement side of things, you know, were they insured? How would we pay for any services that were not insured? Do we want to involve in kind of lab? How would the patient have transportation to and from even our site, and or any potential prescription needs and lab testing. On our side here, we had everyone from our LSU Medicine CEO, our CIO, nursing, social workers on our group, just to make sure everything is covered. What do we have technology wise? Again, it is very rural. We do have issues similar that Robert's having now, even getting connectivity to have a good, stable platform. And then just kind of work with again, our community assessment of what they might need, what we could provide. Looking at, again, is the connection there? Do we have the technology to connect up, even a good, accurate, you know, audio video system to documentation into the electronic medical record. We have that, the training with our on-site telepresenter and nurse. What technology, again, from a provider standpoint, do they need? Do they need just a Bluetooth stethoscope? Do they need an ECG? What other, you know, otoscope? We want to do any kind of derm? Do we need that special lens? We just kind of looked at everything in a big picture of what are we going to try to focus on, and what equipment we need, and then again, do we have the buy-in from our administration side that this is what we're going to do. So we were able to narrow it down, that we were able to commit X number of hours per week on a set time, so that we knew on our side this is what it would take to do a telehealth successfully, and then from the community side, when we would be open, you know, what kind of patients we're going to be taking in, and whether insurance is required or not. So we've been up and running for about 2 months now, and you know, we've actually been able to kind of expand what we did originally. We started very narrow with just some primary care and no real labs or point of care testing. But after we've been there and see some of the needs of the patients and what we were able to do on our side and again, our capacity, we were able to extend into covering more labs. And then also, again, implementing hopefully in the next month point of care testing for some of these folks. As I mentioned, we do have a large elderly population there. So one thing we looked at as well is providing transportation. So we were able to work with the community and we have a van that can go and pick up some patients, bring them in, also take them for any kind of labs. And we do kind of a weekly prescription run to Tulsa to get any kind of prescriptions that are needed for refills for those patients. So again, we've been going about a couple months and it's been great. It's a little bit slow at the start. It seems like with some of the smaller communities, you really need to have a good buy-in and some really good experience with those first few patients, and that we are going to be there continually, ongoing for these folks to really kind of buy in that, yeah, this is a viable clinical experience and that we will be there if needed. So it's been great. A lot of marketing. We try to do some marketing around town, again, a very small community. So word of mouth. We had some kind of city counselors kind of on our little needs assessment, and they've been able to go back and spread the word. We've done marketing through Facebook, a number of different little Facebook groups for the community, signage around the town, and any kind of a town meeting. We're certainly there to discuss and answer any questions we have. So relate that. So.
Well, it must feel great to kind of see the going from needs assessment to seeing patients. That's really exciting.
It is very exciting. Yeah, and it's not a quick process either. It's not something you can start today and by next Tuesday have a program going. It does take getting people to the table, committing, and giving them a realistic understanding of resource time, money, technology, anything we may need to purchase versus what we can already have. And that's something we did do. We tried to kind of repurpose a telemedicine cart we already had. So some of this technology does get very expensive. So what do we really need? What do we have on hand already that we can use and meet the needs of the provider and use it that way? So try to keep costs low, but also providing the maximum benefit to the patient. And letting the provider do what they need and have all the resources they need. So yeah, it's very interesting. And we have everything from young to old to primary care, just kind of touching in, doing almost a yearly screening to hey, this person really needs to see a specialist and get advanced care. So it does make you feel good that you're helping folks who probably would not have had a chance to see a provider, who knows how long, within maybe a couple of years. They just didn't have the way to get out and about or the resources to do that. So, yeah. And again, I apologize. I went through that very quickly, but I know Karen and Eve-Lynn, again, covered most of the other kind of needs assessment pieces.
I really appreciate what you said about the transportation piece too. That seems really smart to think ahead, what kind of challenge could be a barrier and addressing that early on.
Sure. So that was really the two, I would say, large barriers we've had. One was transportation, and two, again, was just the trust of, a large urban healthcare university coming in. Are we just going to come in and tell them, what they need versus coming in and really partnering with the community to see what kind of, patients they had, what needs they had, and how we could help them. I did see a question, I think, from Heidi. I believe you were from Oklahoma as well. The community we're providing is in Avant, which, if you're from Oklahoma, is about 45 minutes north of Tulsa and about 25 minutes north of Skytip, another small community.
Wonderful. Again, that that just really, it's where the rubber hits the road, and that really is a great example. So thank you. You know, I know we're down to about 5 minutes, so I would just invite our participants to unmute themselves and ask any questions across our participants today. I'm going to move the slides to some of our resources, and just know that the slides will be sent out at the end of the presentation. So we'll just be sharing some of our Heartland Telehealth Resource Center, but also some broader needs assessment resources that are out there. We do welcome your questions and also technical assistance as you're looking toward a needs assessment or some of the excellent policy and clinical questions that were asked today. So please do keep in touch. I put a plug in for our Telehealth Unmuted. It's a really great episode this month looking at diversity telehealth.